welcome you back to our webinar series. Our webinar today will discuss advanced care planning, palliative care, making family decisions. My name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Lynn Taylor. Dr. Taylor is Director, Palliative Care Service, Director of the Brain Tumor Clinic, and a neuro-oncologist, Tufts Medical Center, Cancer Center. She is also an Associate Professor, Tufts University School of Medicine. Thank you for joining us, Dr. Taylor. You may now begin your presentation.
Thank you, Joanne, and I would really like to thank the American Brain Tumor Association for this opportunity to speak about a topic that is really near and dear to my heart. Advanced care planning and palliative care, making family decisions. So I thought I would start with a history of palliative care as a discipline, build on that a little bit, and then lead into a discussion about hospice, end-of-life issues, and how to talk to your doctors about these topics, which can be, of course, very sensitive and difficult for all of us to talk about, both patients, families, and healthcare providers. So the history of the palliative care movement as a discipline really began in 1942 when the first hospice facility was opened in France. The hospice movement, of course, was initially associated with dying patients, and over the history of the time of palliative care and hospice, they've been linked in a lot of people's minds. Only in recent years has it become very clear that they are two very important but very different and distinct parts of the care of patients with significant illnesses. So in 1967, Dame Cicely Saunders opened St. Christopher's Hospice in London, which at the time was really a groundbreaking concept, a beautiful small home for patients to move into when they were near the end of their lives. And she devoted her life's work to the hospice movement, which we'll talk about a little bit later on in the presentation. In 1975, Dr. Balfour Mount founded the Palliative Care Service at the Royal Victoria Hospital in Montreal, beginning the proud palliative care tradition of surgeons in the palliative care world. And this is Dr. Balfour Mount. As I mentioned, he's a urologist and a surgical oncologist who said, "You make a difference when you recognize the complex cascade of feelings, reactions, and fears that come to the surface when we contemplate our finite nature." Clearly a very deeply philosophical and thoughtful physician about issues that we confront when we're very ill or facing a and I think it's very interesting that the palliative care movement is very multidisciplinary, and you can see here with her background that she began as a nursing student in 1940. She then went on to get a bachelor's degree in 1945, became a social worker in 1947, and then 10 years later actually went back to medical school to get her MD degree. So in a single person, she basically created all of the many elements that we so depend on in the palliative care movement. And she founded the hospice movement, at least in England, with the opening of St. Christopher's Hospice in 1967. So I know Dr. Alan Carver has spoken as well on the role of palliative care. He's one of my colleagues, a neuro-oncologist at Memorial Sloan Kettering Cancer Center, but I think a little bit of discussion about that before we start the advanced care directives and other part of this presentation is in order. So palliative care is not hospice care. Palliative care is really the total medical care provided by an interdisciplinary team, and as I've already touched upon, that includes the professions of medicine, nursing, social work, chaplaincy, and a variety of other healthcare professionals, all solely focused on the relief of suffering and support for the best quality of life for patients facing serious life-threatening illness. I think it's interesting to note that the palliative care movement is considered, I would say, a disruptive force in hospitals, in part because the palliative care team really changes the focus to what the patient wants, what the family wants and needs, and moves towards symptoms and helping patients and families decide what they will need to know in the future to take control of their care. And so the treating team can really focus on the diagnosis and treatment of the disease, in this case the brain tumor, and the palliative care team can focus on symptoms and also helping patients decide what direction they want their care to go in. Because one of my hats is to be a neuro-oncologist engaged in the active care of brain tumor patients, I know that my decisions for my patients are influenced very heavily by my relationship with my patients, and I want my patients to do well. And so there's a definite tension that's set up in the treating physician and the patient and family that we all want the treatment to be going well. And I think it's very, very helpful to have a dispassionate team, a team that's a little bit removed from the care of the patient, the palliative care team, to focus on, what really are your goals for your treatment, what are your symptoms, and are they being managed in the best way that they can be managed. So the world of palliative care was changed quite a bit in 2010 when this very classic article was published in the New England Journal of Medicine. This is Dr. Jennifer Temmel's article on the early palliative care in patients not with brain tumors but with metastatic non-small cell lung cancer. And I won't belabor this paper or the details of this paper, but the point is they randomly assigned patients with a significant new illness, which is non-small cell lung cancer, which had spread to other parts of the body, and half of the patients received standard disease-directed care, chemotherapy, radiation therapy, surgery, and only received that care alone. The other group received the exact same standard care, but in addition, they had some early palliative care integrated, and then they looked at the patient's quality of life, their mood at baseline and at 3 months, and collected more information. These were the palliative care interventions that they gave to patients in that study, and you'll see something that we'll return to later, and that is a lot of focus on the understanding of the illness on the part of the patient and the family. They provided a lot of education. They offered clarification of treatment goals. Yes, you can see they did a lot of symptom management, focusing in this case on a set of symptoms that are consistent for lung cancer patients. And obviously this kind of study, doing early palliative care interventions, is actually one that very much needs to be done for our patients with brain tumors. And that certainly, hopefully, will be done in the very near future. They spent a lot of time, though, on decision making, inquiring about how the patient and family makes decisions, and then help them to make decisions if necessary. They did a lot of work on helping them cope, a lot of counseling, and then identifying a care plan and kind of a roadmap for the future. So you can see that the palliative care interventions that they gave were really an awful lot of education, discussion, communication, and helping patients and families communicate better with their treating physicians. You'll see here that the outcome of the groups at 3 months, the blue bar are those who got the standard care. The orange-red bar are those who got early palliative care. You'll see the percentage of mood symptoms on the left ranging from 50% down, and then the 3 bars represent, in the first case, a depression scale, in the second case an anxiety scale, and in the third case a PHQ-9 scale, which is kind of a combined 9 symptom scale for depression and anxiety. And I think it's pretty clear in each case that the blue bar is much higher. In other words, many more patients had depression and anxiety when they were treated with standard care alone, and there was clearly a decrease in depression and anxiety with early palliative care. But the part of this paper that got really quite a lot of national media attention at the time that it came out was something no one expected, and that was that the patients in the early palliative care arm survived on average 2.5 months longer than the patients who got standard care. And there's been a lot of controversy and discussion about this, but it's been said that if early palliative care was a chemotherapy drug, it actually would have been FDA approved by now. And the reason this was such a groundbreaking study, of course, is that nobody expected a survival benefit for patients with early palliative care, and that has made, I think, a very clear distinction about the differences between palliative care, which needs to be introduced really early after someone's been diagnosed with a serious illness, and hospice care, which we will talk about at the end of the talk, which is different, of course, altogether. So clearly, the earlier you make decisions about including palliative care as part of your care or the care of your loved one, the better. You have to ask your doctor lots of questions, ask for a family meeting if it will help clarify the medical issues. So with that introduction, I thought I would talk about a few general facts about care at the end of life. That is, of course, death is part of life, and many Medicare recipients, about 5%, die each year. I think probably you've all heard that when asked, we all say we want to die at home. Despite the fact that we all feel that way, 40% of these deaths are still occurring in the hospital. And a lot of time is spent in the nursing home. As you can see here, 38% of elderly Medicare recipients spend some time in nursing homes in the last year. The reason I'm talking about the Medicare population is that this is just the best studied population because of the Dartmouth Health Atlas, which we'll talk about in a minute. But this is certainly true for our younger patients with brain tumors as well, that the majority of patients, or far more than want to die in the hospital, are doing so. And part of the reason we're having this webinar today is to try and make sure that everybody is armed with the facts that they need to make good decisions about care at the end of life. Because you'll see here that despite all this information and all this discussion, fewer than 1/3 of Americans have advanced directives, and only 50% of patients with terminal illnesses have advanced directives, although this has increased over the past decade. Before I created this talk, actually, probably sometime last year, I sat my husband down and made sure that we had written our advanced directives and we had filled out our 5 wishes booklet, something that I'll talk about later, but I think it's an incredibly important conversation that we all need to have with our loved ones even before we get sick. So what the studies show about end-of-life medical care in America today: there's certainly a huge financial burden on patients' families and on society at large. There's a lot of feeling of abandonment at the end of life. There's very poor communication about end-of-life preferences, which leads to overtreatment with ineffective therapies, unmet patient and caregiver needs, and very late referral to hospice, which leads to a lot of caregiver stress and a lot of clinician issues too. We are not immune to those stresses, and it's very, very difficult for us when we know that our patients would do better considering hospice care when we cannot have those conversations with patients and families because they're not willing to engage in the discussion. Healthcare costs in the last week of life, from this Archives of Internal Medicine article in 2009, show very high cost, and in fact, higher cost care was associated with lower quality of life, not with higher quality of life, and that was as rated by the patient or the caregiver. We also know that advanced cancer patients who have end-of-life discussions with their doctors have lower health care costs, but more importantly, no difference in survival time and reduced use of painful cardiopulmonary resuscitation, which can lead to broken ribs, chest discomfort, reduced use of ventilators, being transferred to the intensive care unit. And we know from this article in the Journal of the American Medical Association about end-of-life discussions and quality of a life as well as quality of death. We talk a lot about quality of life, and we need to speak more about the quality of death as well. Despite the fact that this was a study of cancer patients, only 37% reported end-of-life discussions with their doctors. Though when they did have those healthy end-of-life discussions, there was less aggressive medical care and earlier referrals to hospice. And as I've already mentioned from the previous paper, they also found that aggressive care was associated with worsening of patient quality of life and very poor caregiver adjustment. I should pause for a moment and just make a comment that even though I spend half of my time running a palliative care service in a hospital and seeing other physicians' patients, I find it is much easier for me to engage in these discussions with other patients, other doctors' patients, and it is harder for me to have those discussions with my own patients. So I actually think if our palliative care team grows, or when it grows larger, I will be referring my patients to my own palliative care team. At the moment, that happens to be just myself and a nurse practitioner, and so we'll have to grow a little bit bigger. But if you are being cared for by a neuro-oncologist or by a medical oncologist, and there is the opportunity to speak with a palliative care team, that would certainly be one of the things that you could ask your neuro-oncology or oncology team about. In this article in the Journal of Palliative Medicine in 2005, Dr. Cherlin looked at communication between doctors and family caregivers, now specific to family caregivers. And these, by the way, are now caregivers of patients who are enrolled in a hospice program. So these are patients who have been felt to be potentially in the last 6 months of life if the disease runs its normal course. And even though these are caregivers of patients in a hospice program, when the caregivers were interviewed, 21% said they hadn't been told that the illness was incurable. 60% said no one had given them a life expectancy estimate, and 40% of them said hospice wasn't discussed, even though they were in a hospice program. And so it makes it clear that we have to have these discussions on more than one occasion, because it's a topic that we all get psychologically and emotionally blocked about, and sometimes things can be said that we just don't hear. Sometimes we physicians don't say it in a way that is understandable. And so as you're engaging in these discussions with your own doctors, I would demand that the conversation be transparent, simple, and that any terminology that is used that is not understood is defined further, and that you try and push your physicians and healthcare teams to have this discussion much sooner. For really all of our brain tumor patients, the discussion in our clinic anyway usually happens pretty much the first time we meet patients, and it's difficult to start the relationship with those discussions, but I think we find that once the discussion has taken place, we can come back to it again at a later time, and it actually allows us to be honest and frank with each other. And believe it or not, these discussions actually sometimes, if we have them often enough, can become almost lighthearted. Caregivers did admit ambivalence about knowing the truth and accepting bad news, and then only 25% agreed with the physician's life expectancy estimate. The timing of this communication from this Cherlin article as well, as you can see here, the proportion of discussions about hospice, the vast majority of them are occurring 1 to 6 months before death, in many cases very close to death, and very few in 6 months or greater before death. And as I said, the earlier this conversation takes place, and the more often the conversation takes place, the easier it becomes. Dr. Cherlin again now studying caregiver understanding, and you'll see here how very important it is for doctors to bring up the topic of hospice, because in 39.5% of the time, caregivers didn't even understand that hospice was needed until days after the physician raised the topic. 45% of the time, they knew that hospice was needed only when the doctor raised the topic, And there was a small subset of caregivers, of course, who knew that that discussion needed to take place before the doctor mentioned it. So I would not hesitate to bring up this topic with your physicians and care teams, knowing this data. I think not enough of our time with our patients is spent on the issue of spirituality. This obviously means many things to many people. It could mean a resounding faith in an organized religion and the sense of community that brings. It can be less religiously focused and more a search for purpose in life. But we certainly know that spirituality can offer patients support, and that prayer is very important in the lives of our patients. And each of us can draw from this during a serious illness, which is why chaplaincy is usually a very fundamental part of most palliative care teams. So what about primary care physicians and their views about hospice? In general, as you can see from this American Hospice and Palliative Care article from 2003 by Dr. Ogle, there's a very positive feeling towards hospice in general, but they also found that there are fairly significant barriers to hospice referral on the part of physicians. 40%, 35 to 46% of whom said they really lacked familiarity with how hospice services worked. There was a big barrier, of course. None of us like to have strangers in our houses, and so there is that barrier from the patient and from the family. And then 68% of the time, families would say typically, quote, "We're not ready." I would say that I try to encourage families to consider the fact that hospice is a Medicare benefit. As we will talk about, it is a benefit designed for patients who might have 6 months or less to live if the disease runs its natural course. But I joke with my patients that they are not contractually obligated to die at 6 months, and in fact, the hospice benefit can be continued in 6-month increments, and I've had patients actually get the benefit of hospice services for as long as 2 years. We touched on this history of the hospice movement already, and I've already mentioned Dame Cicely Saunders and how important she was in setting up St. Christopher's Hospice in London. Everyone, I think, will remember that Dr. Elizabeth Kubler-Ross wrote the book on death and dying in 1996, and she was able to tease out the stages that we all go through when faced with a serious life-limiting illness. These were never meant to be thought of as stages that proceed in order, and I've seen many, many, many people start with denial and stay with denial, but those stages are denial, anger, bargaining, depression, and ultimately acceptance. Not all of us go through all those stages in that order, nor do all of us get to the stage of acceptance. This led to Connecticut Hospice opening in 1974, and in 1978, the formation of the National Hospice and Palliative Care Organization. Just going to touch a little bit on some more information that we have from the Dartmouth Atlas, that staying in an intensive care unit is an indicator of aggressive medical care for patients who may have a life-limiting illness. And the Dartmouth Atlas is available online. You can actually look up information for your state and compare it to other places. You can look up information from the hospital that you're being treated in. And they make a very strong statement that evidence, in light of evidence, that more aggressive care in managing patient populations with chronic illness does not lead to longer length of life nor improved quality of life. And by contrast, the percent of patients receiving hospice benefits indicates less aggressive end-of-life care. And you'll see in this slide that I've put together, looking at a series of Boston institutions compared with some from my original state, which was Washington State. The Washington State institutions are Virginia Mason, Harborview, and they're compared with Boston sites, Brigham and Women's, Leahy Clinic, Massachusetts General Hospital, and Tufts Medical Center. And I think at least using Virginia Mason in Seattle as the West Coast institution and using Tufts as the Boston institution, you can see that there are definitely regional differences in the number of patients with life-limiting illnesses spending time in the intensive care unit, approximately 20% in Seattle and 30% in Boston. And conversely, for hospice referral in the last 6 months of life, at Virginia Mason, this was 38.9% of those who could be eligible being referred, and here at Tufts, 26.2% of patients. So with that as a sort of introduction to the background, what can we do about this as responsible physicians, caregivers, and family members? Well, certainly the first thing to do is to establish a healthcare directive, often called an advance directive, which is a written document in which you appoint someone to be your healthcare agent to make healthcare decisions in the event you are unable to make them yourself. I worry a lot about my brain tumor patients who could have seizures, who could have a sudden change in their ability to speak for themselves, and so we are very much in favor of getting early healthcare directives and to find out who you really want to depend on to make decisions for you when you can't make those decisions yourself. This is a combination of a living will, which documents specific guidance to your doctors about medical treatment, and establishes who is the durable power of attorney for healthcare decisions. So the reason that you want to create a healthcare directive is to authorize a trusted loved one to make necessary healthcare decisions, as we talked about. But it's very important to make sure you choose a person who you know will follow your wishes if you're unable to do so yourself, and will not impose their wishes for your care on you. And so it takes a lot of thoughtful reflection to decide who that person should be. Some of my patients choose all of their siblings. I don't think that's a particularly good idea because many families have different personalities, and obviously at a difficult time when you need them to be making decisions. So whoever you choose, it's always best, really, if you can choose the 1 or 2 people that you know you can depend on to make decisions in the way you want them made. It must be written by you, dated, signed, and witnessed or notarized. And your healthcare agent needs to be someone over the age of 18 years of age who is not your doctor or an employee of your doctor. And as I said, you should choose someone you know well and trust to make decisions according to your wishes. You can include a lot of things in your healthcare directives. You can state your preferences about eye donation, tissue, or organ donation at the end of life. But I think this is a good moment to give specific instructions regarding artificially administered nutrition and hydration. The American Academy of Neurology has spent a lot of time on this topic. A lot of patients and families are very concerned about administering artificial nutrition and hydration. And in general, I counsel my patients with advanced cancer that there's really very little evidence that giving artificially administered nutrition or fluids adds to quality of life or improves survival. And in fact, for feeding tubes in particular, there's very good evidence that putting a feeding tube in place leads to infection and leads to greater complications. And so in general, we counsel our brain tumor patients not to consider that, or rather to consider that feeding tubes are really not appropriate as part of the treatment. We also say that it's true that intensive care units have made a big difference in the lives of some of our younger healthy patients, but in general, patients with advanced cancer do not do well when they're transferred to intensive care units, put on ventilators, or given other aggressive measures. And we'll talk a little bit about do not attempt resuscitation, do not intubate, and comfort measures only. So DNR, DNI, DNH is short for do not resuscitate, do not intubate, do not hospitalize. And a lot of people have a misunderstanding about this directive. This is really just a request to limit the scope of emergency medical care should you suddenly stop breathing or should your heart stop. As we all know, those are not common things to have happen when you have a brain tumor, and resuscitation or chest compressions or using defibrillator paddles to restart the heart does not make sense if you have come to the end of your treatment options and your brain tumor is no longer treatable with tumor-directed therapies. Do not hospitalize is generally clear in our patients who have elected the hospice benefit. So using your durable power of attorney to make clear what your choices are at the end of life in regard to do not resuscitate, do not intubate, do not hospitalize is one part of this, but you should also have the understanding that your healthcare directive is not just limited to those issues, but also touches on the things we've already discussed, which are feeding tubes and use of antibiotics should you develop a pneumonia and those sorts of things. And so it's always best to sit down and really talk to your doctor about what they think is appropriate care depending on the stage of your treatment. 5 Wishes is a great way to document your advance directives. It is in almost but not all states a legal document if it is countersigned by 2 witnesses. You can see that you can get it in a paper copy, and you can also do this online, and I've given you the website there. It's a really great document because it asks very pointed and specific questions about things like what music do you want playing at your funeral service, what is it important for you to have people say about you, about the way you lived your life. And it's the kind of thing where I've seen a huge weight being lifted off the shoulders of patients and families. If we do it early, we get it over with, we put it in a lockbox somewhere, everyone knows that it's done, and it's just not something that has to be talked about again. So 5 Wishes, certainly something we try to have 100% of our brain tumor patients and their families complete. These are some other good websites for healthcare directive forms. I've given them to you here. The American Bar Association, the National Hospice and Palliative Care Organization. The pink form that you see there is the MOLST form from Massachusetts, which is Medical Orders for Life-Sustaining Treatment. In Washington State, this was a bright green. Here in Massachusetts, I know it's bright pink. And these tend to be a different form for every state, but the same concept. And that really is a place where you can say what your wishes are for the things we've talked about: resuscitation, cardiopulmonary resuscitation if the heart should stop, ventilation, transfer to the hospital. It also gives you a space, at least in the Massachusetts document, a place to talk about intubation, other things as well, including the artificial nutrition and hydration we discussed. The U.S. Living Wills Registry is a very interesting site as well. For a small amount of money per 5 years, you can actually upload your living will to this site. They will keep it safe for you. It is compliant with all good privacy practices, and it is then available for any physician or any family member that you allow access. This is a site started by a surgeon who was frustrated that when he needed to make decisions about taking patients to the operating room, frequently either people haven't made a living will or they can't find it. And so this is an online repository, and if you go to that website, you'll see more information there about how that works. So the Medicare Hospice benefit was first offered in 1983. Medicare has Part A, which is hospital insurance, and Part B, which is outpatient care and doctor services. And generally speaking, if you're a Medicare patient, that's an 80-20 benefit. Medicare reimburses just 80% of the cost, and the rest of the cost of your Medicare for traditional care is borne by the patient and the family. The Medicare Hospice benefit was meant to be an additional benefit that covers comprehensive end-of-life care for seriously ill patients. Electing a hospice benefit in no way means you are going to die within 6 months. I think that's why a lot of people shy away from it. Many of my patients and families have the impression that if they sign on for the hospice benefit, we actually stop all active care, and that is not at all true. In fact, there are 4 or 5 pages of orders that I sign for my patients who elect the Medicare Hospice benefit to cover every essential medication needed, from diarrhea to constipation to nausea to pain to anxiety, and it basically gives the Medicare hospice nurse access at her fingertips or his fingertips at a moment's notice to medication that can help you. It is true that you can unenroll in hospice, so there's no reason you couldn't try the hospice benefit if it was appropriate and then decide for whatever reason that it didn't work for you and your family. You'll see here that to be eligible for hospice services, a doctor has to say that you may have a life expectancy of 6 months or less. As I said, you are not required to prove that that's true, and you can get it in 6-month increments. As I said, I've had patients on for several years. There does have to be an understanding and a willingness on the part of the patient and the family that active chemotherapy or active radiation therapy is no longer a logical part of the plan. In other words, you would be stopping chemotherapy treatments that your doctors have determined really are no longer helping and may in fact be harmful. And this will give you access to the services that I show you here, which is 24-hour care. The nurses have pagers and can come to your house in a crisis. There's counseling. It covers durable medical equipment. There is respite care for family members if they become too tired from the daily care of helping our patients. There are medications that are covered, home health aides, symptom management, and then very important bereavement services. And I've seen this be very, very helpful, particularly in cases where there are young children in the home. The bereavement counselors can be very helpful to the children. I think we talked about already who certifies this eligibility and on what grounds. I talked about the fact that we just have to believe that it might be true that it's a 6-month or less lifespan. And the referring provider, which is usually me for my patients, but could be your primary care provider, your family physician, your medical oncologist, certifies that eligibility along with the director of the hospice, which is usually a hospice medical director. And I just put up here a comparison of hospice and home care services just to show you a lot of our patients will allow visiting nurses to be part of their care and will not allow hospice to be part of their care, but you can see the difference is in the hospice, 100% of medications are covered, 100% of durable medical equipment. Yes, they provide counseling, whereas it's very limited in just visiting nurse services. The bereavement support that I've talked about, 24/7 nurses on call, continuous nursing care, respite care, and then a very important point, which is that hospice patients do not have to be homebound, which is a huge quality of life issue because you can go out and still do things and be engaged in your community, go to the theater, have dinner, whereas generally speaking, if you're getting home health, they consider that you are supposed to be homebound. And then there are spiritual services as part of hospice care. So what are some questions you can ask your doctor to kind of get this conversation started if you haven't gotten it started already? And I think some very simple questions to ask would be, first of all, you know, is there something about my cancer that you can tell me that makes my prognosis better or worse? There's a wonderful book called Death Foretold, written by Nicholas Christakis. And in this book, Death Foretold, he did a survey of American medical literature. And in the 1930s, when we didn't have very many medications to use, the literature was very balanced about diagnosis, treatment, and prognosis of various conditions. Now that we have so many important chemotherapy drugs that are so active, the medical literature now is about 95% about diagnosis and treatment and only 5% about prognosis, which means if we shy away from the potential prognosis, that is an important question that you need answered so that you can plan ahead. And if you don't understand what that is, you must try and start that conversation. And then what is the goal of treatment? Is it to cure my cancer or is it to stop it from growing? Also, what is the prognosis for my type of cancer with standard treatment? How and when will I be able to tell whether the treatment is working? And what happens if my disease comes back? And with that, I will end and see if there are any questions that I can answer. Thank you so much.
Thank you, Dr. Taylor. Dr. Taylor will now take questions. If you have a question you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. And we do have a couple that were sent in at registration time. So the first one is, what are the signs that the brain tumor is getting worse?
So obviously that really very much depends on the location of the tumor, and so we spend a lot of time together going over MRI scans. I teach my patients as much as possible to read the MRI scans, and then we very specifically talk about the location of the tumor and what to expect, what signs to expect specific to your particular tumor that will tell you it's getting worse. Of course, there are the nonspecific symptoms of increased intracranial pressure. So when the tumor grows because the skull is a hard bony box, of course, pressure can go up, and certainly if the pressure rises, all brain tumor patients will have increased headache. They may wake up from sleep with nausea and vomiting. So I would say really severe nausea, vomiting, and headache that is unexplained would be a warning flag. Double vision is another warning flag because the nerves that go to the eyes can stretch and create double vision. Sometimes a worsened weakness, so if you have a right-sided tumor which is pressing on the motor cortex or the motor part of the brain, and you are already weak in the left arm and left leg, that weakness can actually get a little bit worse. Sometimes seizures increase, though sometimes in our lower grade tumor patients who have seizures, the tumor can grow and seizures can actually decrease. So I would say a changing pattern of seizures would also be another sign that something might be going on.
Wonderful. And another part of that question was, can you talk a little bit about what the dying process will be like?
Yes, and that's a very, very good question, and a question that I often get asked in a very particular way. In other words, what will typically happen for me and my patients is I'll get a call. I'll get a call from the patient, and then I'll get a call from the caregiver. And each one of them wants the answer to that question, but they don't want the other party to know that they're asking the question. And so many times we've actually had two separate conversations. And I would say that we're all afraid a little bit, or more than a little bit, I think, of dying. And I think one thing that I try to make very clear to my patients and their loved ones is that thankfully, unlike dying of other kinds of cancer where the cancer has spread to the bones or to other organs, dying from a brain tumor is actually, in many cases, can be a very painless and very dignified death. And the reason for that is that when the pressure rises, when the tumor is growing too fast and the pressure rises in the brain, it makes us sleepy. And so the most typical thing that happens is patients get a little bit sleepier and sleepier, less likely to want to get out of bed, spending more and more time in bed, and then one day become so sleepy that they essentially go to sleep 24 hours of the day. And at the point where we sleep 24 hours of the day, if we're not woken up or forced to eat or drink, because those things are never helpful at the end of life and there's a natural moving away from wanting food and drink at the end of life, if we're allowed to sleep peacefully, generally we die in our sleep about 10 days after we go to sleep. And so it can be an incredibly peaceful death. And at those times, we're often spending a lot more time supporting the caregivers and the family members because the coma that comes from the brain tumor growing actually keeps our patients largely free of pain.
Wonderful. That's so helpful. We hear that question a lot. A gentleman wanted to know if you could repeat the name and the author of the book that you just referenced.
Yes, wonderful book. Dr. Nicholas Christakis, so it's C-H-R-I-S-T, Christ, Christakis, A-K-I-S, and the name of the book is Death Foretold, and it's a very, very good review. It's a little bit hard going in spots because it's very good science, but it's well worth reading.
Thanks. A question about, you mentioned that Medicare does cover hospice. How would a family know if their private insurance covered hospice?
Yeah, so that's a very challenging question, and I think it should be a lot easier to find out than it is. Honestly, we rely very heavily on our case managers to call up the insurance and ask that question, but I think that's absolutely something that you have to dig into the details of the policy or actually call up your insurance agent and have that conversation because it's very variable from plan to plan and not as easy to find out as it should be.
Okay. Here's a question. Someone writes that we're struggling to determine our needs right now. The last MRI showed stable tumor but radiation damage that's causing significant deterioration. Since radiation damage can mirror tumor progression, does it mirror the typical length of life in final months and weeks symptoms?
So first of all, I just want to make sure everybody understands you do not have to have evidence of active tumor to be eligible for hospice services. And it sounds like there's some struggle needing more support at home. So this would absolutely be a situation where hospice would be appropriate. If the change is really due to radiation damage, obviously all of us who are neuro-oncologists struggle with this issue all the time. And in the early years during my fellowship at Memorial Sloan Kettering Cancer Center, when we were asking the question, is this progressive tumor or is this radiation, or rather chemotherapy and radiation treatment-related change, and we did surgery. Most of the time when we were having this confusion, both things were present at the same time. If it is, however, true in this case, the tumor is not active and the radiation change or treatment-related change is very active, then our patients can live a very long time in that situation. But I still think clearly it decreases quality of life and leads to a need for services at home. So I think this is a perfect situation to consider initiation of hospice benefits, just to see if the increased support at home can allow you to keep your loved one at home.
Thanks. We have a question about pediatric hospice, wanting to know if the parents aren't ready to accept the end of treatment, but there'll be there's benefits to enrolling the child in hospice. How do you handle that situation?
So obviously these are a series of ongoing conversations, and of course it makes sense that it's so much harder in the pediatric population for parents to let go. We try to help people understand that chemotherapy is not magic, and that of course everybody intuitively understands that you would not give an antibiotic to somebody if the bug was resistant to the antibiotic, just so you shouldn't give a chemotherapy if the tumor is resistant to the chemotherapy. Having said that, however, there are certainly situations where you can get both chemotherapy and hospice at the same time. The majority of hospice medical directors that I have spoken to have all said that what is important to them is that everyone has had a conversation about goals of care and that they understand what the goal of the chemotherapy is. And by this I'm talking about a goal like graduating from 6th grade or going to somebody's wedding or something, some very concrete goal, not just the goal of I want to live longer because I want to live longer, but a very specific goal. And if chemotherapy can get them to that goal, there are times when I've been able to have a conversation with the hospice medical director, explain why we're using the chemotherapy, and then you can do both, give the chemotherapy and get the support you need from hospice.
Thanks. That's a hard subject. And we have one last question. Is the power of attorney or any of the documents that you talked about, is it legal in the state that you are from or the state that you're in at the time that you might have a heart attack or something? So if you're traveling, do you need another form to fill out before you leave?
No, almost all states are very understanding, and as long as you've got that form filled out, the majority of the states now, most of the post and most forms are starting to look more and more like each other. It's really the state that you live in, but more importantly that you've had the conversation and are not that strict. But yes, it's the state where you live, not the state that you're traveling through.
Great. Well, that's all the questions that we have. Thank you all for joining us, and thanks Dr. Lynn Taylor of Tufts Medical Center Cancer Center.
Thank you very much, Joanne. Appreciate the opportunity.
Let's pause for a moment to conclude our webinar recording.